Let's go to Stridor. I don't think any of you can fail a question in Stridor. It's not should fail a question, can fail a question. What do I mean? How do you see an unwell child that is drooling saliva and you want to examine their throat? Don't. That is a GMC problem. Do you know what will happen? The patient will drop in front of you. If the anesthetic is not quick, the patient will pass on. Epiglottitis, do not examine their throat. I beg you. Epiglottitis, H influenza, Haemophilus influenza type B in your exam. It's usually an unwell patient that is drooling. How would you see them? The patient will be seated, pushing their head forward. What's that? It's a tripod sign. Tripod sign is when they put their two legs spaced out, their head is bending forward, they are drooling. That patient is dying. What do you need to do? Please, it's not a 2-week wait. It's not refer tomorrow. It's not try steroids and refer within 1 hour. It is ambulance. Ambulance. That's not the time to say, okay, I've got a special spatula. Let me just quickly look into your throat to confirm that it is not croup. My friends, you are doing something really dangerous. That can land you your license. Don't examine epiglottitis, I beg. Organism, H influenza type B. And now that I've mentioned croup is a cause of stridor, my friends. What would you see? Is a patient that has a backy cough in the AKT. Well, that is going to be para-influenza virus. You see the difference? Epiglottitis is Haemophilus influenza type B, while croup is para-influenza virus. By the way, I don't want to waste much time on this. The treatment will be your prednisolone, or the first line treatment is your dexamethasone, 0.15 milligrams per kg or 150 micrograms. You can't fail it in the exam. Classical candidates in the AKT, all of them know it. Why shouldn't you know it? Well, in the AKT, your lengthy question may tell you that there's something on X-ray. You look at it, it's stipple sign. Especially if it's a posterior-anterior chest X-ray, you will see stipple sign. What else can you see on X-ray? On the lateral view, you can see what we call thumb sign. I just thought I should remind you of this. These are things that when if time you see stridor, you must remember them. Can you see a patient who has a dental procedure, who had a dental procedure 2 days ago? Can you see them in the practice with stridor? You can. If you see them in the practice with stridor, stop taking history. Don't take history any longer. Dental procedure, stridor with neck swelling is urgent referral to A&E. It is a neck space abscess. That's what has happened to that patient. Neck space abscess. How do you not recognize that? It's a super red flag if there's something like that. The patient comes, you are hearing stridor in an elderly patient. The patient says, "Doctor, I had a procedure yesterday. The patient is hyperventilating." What are you doing taking history? Ambulance, 999. Say, "I don't want to hear anything again. It's okay. I just need you to keep calm. I'll phone the ambulance." If the ambulance is wasting so much time, change it make it a blue light ambulance. It needs to be rapid. That patient needs to be in the emergency. They can collapse and die at any time. They can faint at any time. There needs to be anesthetics around. They need to be able to intubate the patient immediately. That is a neck space abscess, my friends. How are you seeing a patient with a rash after a bee sting and you don't know what that is? It's angioneurotic edema. Adrenaline is the answer in your AKT, not steroids. I know some candidates will pick prednisolone, some candidates will pick IV steroids. Please, you will fail the question. It is adrenaline. And if you were in our previous drill class, I've asked candidate multiple times, what is the dose of adrenaline per age? Is the rule of 6. Benzyl penicillin, rule of 10. Adrenaline, rule of 6. You can't fail this question in the exam. Why? They will greet you in the AKT. Your first question may be on benzyl penicillin, a child who have meningococcal septicemia. The child is unwell. What do? You give benzyl penicillin, but that's not what they are asking you in the AKT. What they're asking you is the dose. How come you don't know when we've done the rule of 10? Less than 1, 1 to 10, greater than 10. Okay, that's not my focus for today. We'll do more of that in the drill session. And I want to beg you, if you have been missing the drill session, you are missing a lot. Especially if you're on past confidence, your drill session will usually be repeated only twice. So if you have been missing it, you are missing a lot. For Pass Plus, if you miss it, that's fine. You hear it at least 5 times, so that's not a problem. But you need to attend the drill session. That's what makes you good. That's what gives you the confidence. That's what makes you pass the AKT with an outstanding result. One candidate saw another candidate's result, and the other candidate said, well, you need to speak to Dr. Lekon because because of his help, I was able to get this 90. Well, my friends, it's not because of my help. It's because that candidate engaged in the drill. The drill is where you become good. Another candidate was asking, well, can we get the notes ahead of time? Sometimes reading, you will not, if I can decide to just write the notes and give you the notes. Just go and read the notes. But what we are doing makes it stick. What we are doing exposes you to new things. What we are doing makes you see areas that you need to study. What we are doing gives you the confidence. The repeats we are doing gives you the confidence. And that's why today I have not put anything on the slides. I don't want any sort of distraction. It is audio notes, it's audio points. I want you to just focus. I want you to know these things. I want you to be good. Listening to it the second time, sometimes you will not need to read any notes. But there will be notes. The notes are already ready. We usually send them within 48 hours to you. There will be slides, there will be videos. And for this AKT ENT, there will be podcasts. So you will have short audio listening audios that you can listen to in your car. All these resources will be available to you. But today I just want you to listen and get the point. Okay, you've seen this patient. This patient has got stridor. The patient is 6 weeks old. The clincher is the age, 6 weeks. Well, someone did not get it, so the person continued to read on. If you continue to read on and you see that the stridor is worse online, that is laryngomalacia, my friends. It takes 2 years to resolve. Laryngomalacia, do nothing. Just make sure that the child is okay. There's no respiratory problems. The SpO2 is fine. Fine, just leave the child. It will resolve within 2 years usually. It's because the development is still going on. So that respiratory tract development is not optimum yet. So don't do anything, don't worry. It's not a red flag. It's usually that child that is 6 weeks. They are still in the first few weeks of life. Laryngomalacia is your answer. So I thought you should know all these things about stridor. And these are the top ones that you should know. But moving on, you can see questions about 2-week wait. Questions about 2-week wait, high yield. 2-week wait in ENT, if you see questions regarding nasopharyngeal cancer, 2-week wait. Persistent tinnitus with otorrhea. This patient is discharging from the ear. You ask the patient says, doctor, I've been having ringing in my ear for weeks now. It's a 2-week wait. Don't get into GMC's problem, I beg you. Anything persistent tinnitus with something else, go and check the guideline. It's likely urgent or a 2-week wait. For example, persistent tinnitus in a patient having suicidal thoughts is urgent referral. However, persistent tinnitus with depression is 2-week wait. Someone didn't get that. Let me repeat it. Persistent tinnitus, suicidal thoughts, urgent referral. But if it has turned to depression, 2-week wait. How about tinnitus with hearing loss? Is automatically a 2-week wait. If it is hearing loss after a month, is a 2-week wait. If it's hearing loss within a month, is urgent referral to the specialist, to ENT. I don't think any of you in the practice will be playing with a patient that says, doctor, I've got bloody discharge in my ear and I've just noticed I can't hear well today. Is there an eardrop I can get? I don't think any of you will be playing with that patient and be smiling and say, well, I'll be able to give. No, it's a 2-week wait, my friends. You need to be smart. Sometimes you need to be smart, even if you don't know the guidelines. You need to be smart to save your license. Bloody discharge in a patient with sudden deafness is a red flag. Even if you don't know, you know that that's not a primary care treatment. It is never a primary care treatment. Refer. Okay, you've seen this patient. This patient has got unilateral middle ear effusion with deafness and is not due to an infection. What else will it be due to? It's cancer. If you are seeing effusion, cancer causes edema. You are seeing effusion in a patient and the patient doesn't have an infection. What else has caused the effusion? Think wide, think broad. It's a cancer, it's a middle ear cancer, it's a 2-week wait, my friends. Now, talking about 2-week wait in mouth ulcers is high yield. If you've seen an unexplained ulceration in the mouth, that's in the oral mucosa, and this thing is persisting for more than 3 weeks, it's a 2-week wait, my friends. Some people don't know that unexplained red and white patches in the mouth is automatically a 2-week wait, including even if it is lichen planus. Please, you need to know in lichen planus, the mouth presentation is what we call Wicham striae. Wicham striae is a whitish cuddly stuff in the mouth. It is different from red and white patches. So the patient may say, doctor, I have a history of lichen planus. You say, okay, and now I'm having this thing in my mouth. I think it may be due to the lichen planus. If it's red and white patches in the patient's mouth, it's a 2-week wait. Especially if the patient comes and says, and then it's just one of it bled yesterday. What are you doing? Bleeding, unexplained 2-week wait. Swelling in the mouth, unexplained 2-week wait. Squamous cell cancer. Pain in the mouth, of the tongue, of any part of the mucosa, unexplained 2-week wait. Lichen planus, mouth problem is Wicham striae. You see it's whitish. Another thing that can be whitish in the mouth, candidiasis. Whitish cuddly stuff in a baby's mouth can be the milk from the mother. It is not everything that is a pathology, my friends. Sometimes you need to tell your brain to calm down. Some things are normal. In the AKT, you can get a normal eardrum. It's not everything that is a pathology. So don't go and pick that the patient has otosclerosis or any other condition when what you are seeing is a normal eardrum, normal tympanic membrane. Some things are normal, physiological. Some are pathological. But the way the AKT wants you to think is everything is pathological. No, some of the answers are normal findings. You need to know them. Okay, still on the mouth, you've seen a patient. The patient has been having signs and symptoms that are related to the oral cavity and is having this persistently for greater than 6 weeks. You've tried to diagnose it. You've looked around. You can't see any condition that looks like that. You are unable to diagnose any benign lesion in keeping with that. Is a 2-week wait. This means unexplained mouth cavity problems, 2-week wait. While we are here, I just thought I would just talk about some reasons for urgent referral. One candidate I asked about otitis malignant and malignant otitis externa, and he says a 2-week wait. Is not. Is an urgent referral. Malignant otitis externa is not a 2-week wait, unfortunately. Is on the NICE guidelines is urgent. Another one that is urgent is if a patient has had a neck or head injury and now they are beginning to have hearing loss. What are you doing? Don't wait for 2 weeks. So there are some things that cannot wait for 2 weeks. You send them same day. Malignant otitis externa is one of them. By the time it's 2 weeks, by the time the patient comes back, it's 2 weeks, it has spread. It has now become widespread cancer, my friends. Again, head and neck injury, by the time it's 2 weeks, the bleed is, but the patient has paraplegia, complete paralysis, quadriplegia. It will be the doctor's fault. Let me just announce that to you very quickly and clearly. So when it's urgent, know when it's urgent. When it's 2-week wait, know when it's 2-week wait. For example, stroke and hearing loss is not a 2-week wait, it's urgent. For example, unilateral focal deficit and hearing loss is not a 2-week wait, it is urgent, my friends. So, my friends, 2-week wait, you need to know it, and this is how it can present. It can present in any of these ways, and you need to be good. Well, there are a few other 2-week waits I've left away from this because they are not things that are super urgent. You don't see them in the GP practices. They will less likely not show up they will most likely not show up in your AKT. If you've got some time, when you are studying the high yield 2-week waits, when you finish, you have more time, you can go and study the less important things. Okay, throat problems in the AKT. Well, many people can present with throat problems. And if I decide to spend 20 or 10 minutes on throat problem, it will be counterproductive. Why? We're on slide 7, we still have slide 40 to go. So we have 33 more slides to go, and you can see the time. So what I'll just do with throat problem is I will give you high yield points. If you see a very well patient unable to eat, please think retropharyngeal abscess. Don't worry about writing. If you are not writing, your slide has all these things. So retropharyngeal abscess will be an unwell patient who is unable to eat. Now compared to this patient who has got pain on swallowing and fever. The difference between the first and the second is very clear. One can eat, it's just that when he's eating, he has pain. The other one is seeing the food, cannot eat. Retropharyngeal abscess is too unwell to eat. What does that tell you? He needs to be in hospital. It is not a GP practice treatment. Meanwhile, this second patient that has got a fever and pain on swallowing can eat. That's tonsillitis. Tonsillitis. Now, compared to this third patient I'm going to give you, who has drooling and sore throat and pain on swallowing, is Quincy. Quincy. Now someone is saying this is becoming too much. Don't worry, we'll take a break very soon, but you have to get this point now. Retropharyngeal abscess, the question will be depicted as a very unwell patient. You can't miss it. The patient is very sick. The patient needs to be in hospital. The patient needs inpatient admission. How else do you want me to say it to you? Okay, if you see this well patient, the patient walks in with mom. Mom says the only time he's got discomfort is only when he's swallowing. That is tonsillitis. By the way, the rule for tonsillitis, tonsillectomy is 71, 52, 33. Someone is asking what is that? I will tell you. 71 is 7 bacterial tonsillitis in 1 year, refer for tonsillectomy. 52, 5 bacterial tonsillitis in 1 year, in 2 years, refer for tonsillectomy. 33, 3 bacterial tonsillitis in 3 years, refer for tonsillectomy. I hope that is clear. Well, if you see drooling, sore throat, maybe a mass on the neck, just a small one, think Quincy. Quincy is also unwell, but not as unwell as a retropharyngeal abscess. By the way, an abscess will cause high fever. An abscess will make the patient very unwell. Now, this abscess is in the retropharyngeal region. Think about a very toxic, unwell patient. So those are 3 points that you can contrast and compare, because in your AKT, the option A will be retropharyngeal abscess, option B will be tonsillitis, and option C will be Quincy. This is where you begin to scratch your head. The answer is not on the roof. The answer is in the points that we have just discussed, and you need to be good. You need to be able to get the answer in the AKT. Now you've got a patient with sore throat and rash. Think wide. Someone is saying sore throat. What does sore throat have to do with rash? It is pityriasis rosea, my friends. If you have not listened, if you did not join the dermatology class, go to the YouTube page and listen to dermatology. Pityriasis rosea will present with a herald patch 2 weeks before the other papules or plaques come up. Pityriasis rosea, high yield in the exam. Treatment, no treatment. This is where someone will start to give ketoconazole. You failed it. Pityriasis rosea is not due to Malassezia 4:4. It is not due to a fungal infection. The treatment is no treatment. How do you spot it? There will be a big, in the AKT question, there will be a big patch, and 2 weeks later, there will be multiple small patches everywhere. Pityriasis rosea, forming a rose flower or a Christmas tree sign. Okay, how about this patient that has presented to you with sore throat, joint pain, and tired all the time? Chronic fatigue syndrome. If I have not talked about chronic fatigue syndrome today, it's because I want you after this class to go and read everything about chronic fatigue syndrome. You need to know all the points, the 7 or the 10 gated points for chronic fatigue syndrome. You need to know the management. So if you see graded exercise therapy, when is it the answer? If you see use of medications like amitriptyline, when is that the answer? Because that's not the focus of today, because I know once I enter into chronic fatigue syndrome, I must finish it. I will not enter into it. But I want to beg you, go and read chronic fatigue syndrome. Write it down. Look at it. It takes 3 to 5 minutes for you to have an overview of chronic fatigue syndrome. It comes out in the exam, and that's why I'm begging you. How else do you want me to beg you? I can kneel down for you to go and study chronic fatigue syndrome. If you are studying chronic fatigue syndrome, why would you take the time to also look at fibromyalgia? What are you doing if you look at chronic fatigue syndrome and you don't look at fibromyalgia? Because in the AKT, it will be a lengthy question, and option A will be chronic fatigue syndrome, option B will be fibromyalgia. You need to be able to differentiate them. By the way, if you see sore throat and teardrop papules, that is gottate psoriasis. We've done psoriasis again in dermatology. We did the 7 different types of psoriasis. If you've missed it out, go and watch that video on YouTube. If you've not missed it out and you've just forgotten, take your document. All of you must have gotten the document. Take your document and do a quick recap. That's the aim of the document, so that you don't spend time watching so much 3 hours, 4 hours of watching. 4 hours of watching is now. Towards the exam, you can't do that. You need your quick reference document, PDF. You need your quick reference slides. By the way, if you've not gotten cardiology document, please reach out. Everyone should have gotten that for the people with email. So if you are submitted your email and you've not gotten the full cardiology document, the full cardiology links, just like you got your dermatology, please reach out to Yemi. Just message him. He would make sure you get that ASAP. How about a patient with strawberry tongue? I don't think we should be discussing it. Sore throat and strawberry tongue is scarlet fever. Scarlet fever is 24 hours school exclusion. I don't think we should be talking about it, because it's something that all of you know at the back of your palm. Sore throat that is not going away is a 2-week wait. The patient has sore throat last week, has sore throat this week. You see the patient next week, he's still having sore throat. You are already suspicious. In 5 weeks' time, patient is still having sore throat. That's a cancer. That's a cancer, my friend. Unexplained sore throat needs to be investigated. Is a 2-week wait. 2-week wait.